So let's move on now to consider the affirmative approach and gender-affirming care. So I just put up a bit of a timeline there to show that the gender-affirming approaches to children and adolescents historically overlaps with the development of some of the key cultural frameworks and how they've entered psychotherapy. And I would add that there are other important cultural structures and just broadly the cultural landscape, in the cultural landscape, that have also been occurring at the same time as these developments. And you might think about postmodernism, rise of postmodernism. Some people would want to think about the rise of neoliberal capitalism, but these have all happened over sort of similar time periods. And that might be important. So the affirmative approach. So all psychotherapy models are culturally situated. Psychotherapy does not arise outside of its culture. The models we use often reflect dominant moral values, our political histories and epistemologies. And of course, the affirmative model is no exception. As I said, it's evolved alongside and has been highly influenced by emerging cultural ideas, especially, I'd argue, anti-oppressive and minority stress frameworks. I just want to, note that not everybody applies the affirmative approach the same way, and there is, a huge range of ways that people use the affirmative approach. But some people do propose that the affirmative model should actively help clients, or we should actively challenge cisnormativity, heteronormativity, any kind of enforced gender conformity, binary and reductionistic models of sex and gender. And some proponents of the affirmative approach would also say that we should be looking at psychotherapy and diagnostic traditions themselves, because we have got a history of pathologizing gender nonconforming and gender diverse people. So the affirmative approach prioritizes client self-definition, autonomy, and well-being over any normativity or pathological way of framing gender diversity. And the model, I would argue, is informed, remember our biopsychosocial frame, socially by community knowledge and social justice approaches, and medically via strategic engagement with medical and diagnostic frameworks. And it's not really that psychologically informed. It's not a psychological theory in the traditional sense. And maybe that's happened for a reason, given our history of pathologizing gender nonconforming and gender diverse people and sexualities as well. But there are tensions, obviously, with that word again, within the affirmative approach. Some people use the model to argue that any kind of questioning of the model or of anyone's felt identity is non-affirmative, which puts us in a difficult position because we psychotherapists are taught to question. And when questioning is treated as harmful, it forecloses inquiry, disagreements are pathologized, and potential coercion can be reframed as care. I'm thinking there of would you rather a live daughter or a live trans daughter or a dead son kind of narratives that have come along with that model, and that some clinicians, not many, but some have used. And so the affirmative model, like any other model that we use, can be seen, this is Rubin's vase, by the way, that can be seen as both the solution, but also potentially a problem. And I think that helps us understand why some people can look at gender-affirming care and see it as harmful, and some people can look at normal explorative psychotherapy and see it as harmful in the same space. And it also helps us understand how, so looking at Rubin's vase again, some people can see explorative psychotherapy as actually equivalent to conversion therapy, and some people can see the medical affirmative approach as equivalent. to conversion therapy. But there are risks of not affirming a non-affirmative practice, I would argue, including a return to those pathologizing frameworks for gender nonconforming and LGBTQ people, under-recognizing gender and identity as clinically salient and important thing to work with, undermining subjective experience and self-understandings. And I think that's key. I think that can be very harmful for a client who comes to work with us and who is vulnerable and who has a very clear sense of who they are. If we don't affirm that in some way, not necessarily confirm, but we do have, we are trained and it is our ethics to work with the subjective experiences as meaningful. Not using affirmative practice risks us returning to unexamined prejudice and normativity at its worst. I think people fear that not affirming could lead to a re-emergence of some kind of conversion or reparative practices. And I think this is really key, that in a culture which talks about affirming as the only way to, affirming at the medical level as well, is the only way to really validate trans experiences. Anyone who's not affirming might not be trusted by LGBTQ clients. So there are risks of the affirming model and risks of not using an affirming model. So what are the tensions for us as psychotherapists? Remember, we're working with young people. So how do we affirm a young person's subjective and lived experience and reduce any harm that results from stigma or prejudice because that person is non-conforming, without turning that affirmation into a reductionistic and foreclosing experience? Let's go back to the idea from Cass about how gender-affirming care, the gender-affirming model, risks diagnostic overshadowing. So, as I just talked about, the model itself pursues gender-affirming care and gender-affirming medical treatment sometimes instead of or in place of psychotherapy. Because the model is predominantly medical and social, psychology and all psychological understanding of how humans work and how humans are impacted by various things that they struggle with can be overshadowed by the use of the model itself. And a purely affirmative approach can become psychologically unsound when we're working without an evidence base, when we're working with people whose decision-making capacity is developing or fluctuating, which arguably we always are when we're working with children and adolescents. The model that so centers patient choice risks us framing those choices, a patient's decision as choice, when we haven't explored things that they may not be aware of, like trauma, coercion, or internalized stigma. If we take away psychological thinking, it can be psychologically unsound to affirm something or someone when insight is developing or limited. Again, we're working with children and adolescents, and affirming can also be unsound psychologically if there are safeguarding conflicts of doing so, as I talked about, the iatrogenic harm of the potential harm of irreversible interventions. So what should we do about this? I've talked so much about all these cultural and ethical tensions. So how do we minimize them in our practice? So this is a paper I wrote last year that was attempting to turn the sort of procedural ideas from Cass into something helpful for psychotherapists. And a lot of these ideas come from that paper. So we do need to be structurally competent and culturally competent and clinically humble, culturally humble. How do we do that? Well, I think we do have to listen to and engage with LGBT communities. We absolutely have to recognize that these people do experience stigma and harm. And that might even be from our own professions. And we have to understand all of this the history of it so that we can understand why we're here and why our client is here. So understanding the development of the affirmative therapeutic stance, how gender-affirming medical treatment developed with young people, I think is key for being culturally competent. Understanding the culture, the generational differences in terms of the beliefs around sex and gender, but also that our colleagues might hold different beliefs to us about sex and gender. And we need to stay informed about the structural side of things. So the current clinical guidelines, legal guidelines, social debates that are ongoing. And that in this field means understanding what's happening in our country, but also possibly internationally, particularly because the young people we work with are often connected internationally through the internet. For psychotherapists, I think we have to really stay aware that cultural and medical frameworks might be overshadowing the psychological frameworks we usually use with other young people in our work. And all of the time it's thinking about how does this impact our clients and how does it impact on us? What does it mean to work in this area and what are the risks to us of working in this area? We have some tools that I think help us also stay culturally, structurally competent and humble. I would argue that clinical formulation, I think you guys call it case conceptualization more often, is a key tool for helping us stay aware of cultural influences and hopefully mindful that we ourselves can be biased given where we are in our societies. So we know what a clinical formulation is. It's a core professional competency to integrate information from an assessment with our psychological theories and ideally an evidence base to make sense of distress and develop a way to move forward and offer treatment or care. I just want to point out that we talk about formulation as if it's something only psychotherapists do, but actually it's something all humans do. We all develop theories about why people do things. So, we'll all be going, well, I think he left her because of what happened with his mum in 2012, so humans are always formulating about themselves and other people. So if somebody isn't offering a clinical formulation, it doesn't mean they aren't being led by a formulation. And I think the risk is when that formulation is implicit rather than explicit. When we make our thinking explicit, it allows us to be a bit more objective and interrogate it a bit more. A clinical formulation has to, in this field, draw on all the possible biopsychosocial factors that are impacting a young person's experience, including the systemic and cultural ones. And I think it needs to be transparent for it to be ethical. As I said earlier, when I worked in a gender clinic, we'd never used clinical formulation. We only used diagnosis. And I think what that meant was that we weren't having to grapple with the assumptions that we were working to, and the clients and the families didn't have to either, or were engaging in treatment without being given that information, which I think is unethical. So it's a really useful tool to guide our treatment approaches, but also to help us be culturally competent and mindful of our own potential biases. And by putting our cards on the table, it allows us to be open and ethical and collaborative. It allows us to be transparent. This is what I'm thinking and why. And we have to share what we're thinking and why with our clients for them to be informed enough to consent to working with us. If you're a wholly affirmative practitioner and you think you were born trans, and that's why I'm recommending gender-affirming medical treatments, if that's the thinking, the client and family need to know that that's what's driving the treatment recommendations. If, like me, you're a traditional psychologist, psychotherapist, and you think all identities develop for complicated reasons and can be understood for a psychological framework, and you're offering exploration, then the client needs to know that that's what you're offering. Otherwise, it becomes potentially coercive. And just a caveat, when working with young people and children, especially when we're working with deeply valued beliefs and identities, there needs to be careful thought about how we share formulations. So we might not hit them around the head with it in the way that we might with a CBT formulation for anxiety. It might be a very gradual process of testing out how a young person and or family respond to different ideas, different beliefs that are in the field. So it should be transparent enough to support their autonomy, but not overwhelming.